Yeah, I think, there are lots of possibilities how we can combine these, but I think one aspect which I'm really interested in, and there's already also clinical trials going following this concept, is utilizing adapter CAR T cells. So that's in some sense you have an adapter like a bispecific who's binding to a universal CAR T and with the other arm binding to a target antigen on AML cells. And this has several advantages. So with switching the bispecific or the adapter, you can switch target antigens and do parallel or sequential targeting. And you also increase safety because most of these bispecific or small molecules have a short half-life. So you have sort of an on-off switch for the CAR T cells. And there has been a recent report in Blood of the first patients from a group from Dresden showing feasibility and demonstrating that you can turn on CAR T cells when you infuse this adapter or bispecific, and you can turn off the CAR T cells once you stop. So I think this is an interesting approach. And one can also, we've seen that in the B-cell malignancies, also combine our already existing CAR T cell directed, for example, against CD19 followed by a bispecific to possibly expand already transfused CAR T cells. So there's been several reports where bispecifics like glofitamab directed against CD20 have been used successfully after CD19 CAR T cell therapy. And they could actually show that also CD19 CAR T cells were expanded, so having the advantage of sort of reinvigorating the CAR T cells and at the same time targeting two antigens, then CD19 and CD20. But this is almost anecdotal data. We don't have any clinical trial data in this context yet, but I think it might be a very interesting, albeit expensive approach.